We are here to discuss more evidence-based practice in polypectomy. We are going to just see the objectives for this session. Before we start, we've still got Ralph Lee with us in Zoom. I want to apologize to Nick Burgess, who was, due to a technical error, not able to be boarded in the previous session. And we will see, if possible, although it is 1 a.m. where he is, to get him in this session. If it's possible, it may not be. Otherwise, we'll put that all online. The evidence-based practice, what's the objectives of this session? When to mechanically ligate pedunculated polyps. That will come in a little while because we're running a little behind in the live. So after Michael's just shown us some clips here, we will go to that. How to choose the right snare, how to correctly perform cold snare polypectomy. That may also be online if we have to mix it out with Nick Burgess' talk. Describe techniques for avoiding and treating post-polypectomy bleeding. That will be Michael doing that. And then serrated polyps, an update for 2022. Please, let's hear about the technique you're using to clip this.
Closure. Okay, yep. So slowly close, close. Okay, fine. So you want to, so first of all, you need to make an assessment of whether you'll be able to achieve a complete closure or just decrease the footprint of the size of the resected area, which, if you think about it, a lot of pressure goes into the right colon, and if you have a mucosal defect with vulnerable vessels that are sublethally injured, then at some point with the stretching they'll bleed. So if you can just cinch it together a bit, it's going to be much better than, I mean, of course, if you can close it totally, that's perfect. But a lot of these big defects you can't close totally. So the best thing is to try and cinch it together, and that will reduce the shearing forces and expansile tension on the post-DMR mucosal defect. And we know from the data that partial closure, so full closure reduces bleeding risk in the right colon from 10 to 12% to 3%, and partial closure takes it down to 5%. So, and there's good evidence. There are 3 large randomized trials, including our own, which was just published in Lancet GastroHep. So now then the next thing is, you don't want the stems of the clips to fall across the wound.
You should look that up. It's quite interesting. Now, David's already shown the WASP criteria by published by the group in Amsterdam. So we're looking for a mucus cap. And the mucus produced by a serrated polyp, make sure that stool adheres to them. So when you see a perfectly clean colon, especially on the right side, and then you see a little bit of stool, it should really immediately draw your attention. It's not a little bit of debris left. It's usually because it adheres to the mucus of a sessile serrated polyp. The surface is cloud-like. There's a finely nodular surface, indistinct borders, irregular shape, and the lesion appears paler than the surrounding mucosa under virtual chromoendoscopy. These are some nice examples. You see on the left side what I meant with stool adheres to it. This is obviously a bit emphasized, but you can see this perfectly, just one lesion, just a little bit of stool, just always go and check. Now we need to detect them, and how can we improve our detection rate of SSPs? Well, obviously studies have been done comparing high definition white light and narrowband imaging. It doesn't reduce the polyp miss rates in patients with serrated polyposis syndrome. Dysplasia within sessile serrated polyps. I know I go quite quickly, but there's so much to show you, so I have to. Michael's already.
I must say, this is one of the things that you ask us the most about. We get more questions about snare size and diathermy settings than we do about many other things, and I think that therefore is worth devoting some attention to it. And so if you're watching this session, please ask questions and put your comments so that we can address those as well.
Okay, so we'll talk a little bit both about snares and diathermy and how to choose and when. And to be honest, when looking at snares and what we should choose, there's such a big variety of snares in all types and sizes and shapes, and different companies who make them. And I find that if you ask 10 endoscopists what their favorite snare is, you'll get 15 different answers. So it's really up to you to try a few. But there are some basic principles that you can adhere to. So you need to know that there is a monofilament snare versus a braided snare, okay? And you often use the braided snare when you have a flat polyp because it tends to slip less than a monofilament snare. You also need to know that when you're using cold snare, although Michael mentioned this today, there is no complete or very strong data to show that for cold snare polypectomy you should be using dedicated cold snares, but I think most of us are using them. And the basis of a cold snare, a dedicated cold snare, is that the wire is significantly thinner. So these are like major concepts or the main concept that you should know about snares, and you should choose your own. So some practical recommendations for polypectomy. You can use a blended current such as endocut. Q, you can get a cut duration which you can change, but it's usually this is the standard per setting, and your intervals will be shown here. And in between the cutting and the next cutting, during the interval, you will get the coagulation effect that you can also change here on the device. You can also use the forced coagulation mode, which gives you more coagulation but does give you some cutting, and that may be helpful in large impedunculated polyp with thick salts, so you can get some more coagulation effect during your resection. You need to try to avoid deep coagulation, because if you do that, you can increase the risk of a delayed post-polypectomy bleeding. But the coagulation has advantages, because if you use just pure cutting, you can get immediate bleeding, and that's undesirable.
And at the back, we see clear evidence of cancer.
It gets even worse.
Yeah,
So can I ask you a question, everybody in the room, and some suggestions about this? Maybe we start with Ralph. Why this patient was scoped at our hospital, I will declare that. And the patient had a full colonoscopy and was referred from one physician to another with the diagnosis of 2 pedunculated polyps in the sigmoid. So how has that happened?
Well, I was actually wondering myself while I was looking at that, and I was wondering how we can raise the awareness and a better assessment of lesions like this.
Because I mean, to be fair to the person who did this, if that was pedunculated, that changes it totally, right?
Of course, yeah.
Like that imaging, that you would still resect that. You still could go for that if that was pedunculated.
Even as a subpedunculated polyp, it could be resected, only that at the back.
Yeah.
So if the changes were at the tip, you could still do it by ESD with the hope that cure could be achieved by criteria, but the changes extend well down into the polyp, so it's...
Ralph, what's your opinion about why someone's referred that as a pedunculated polyp alongside the other one?